Hello, welcome and thanks for joining us. We're just going to give this another minute or so to get more people on the line and then we'll begin. Okay, so I can see that the number of attendees is still going up. We'll start now. Good morning, good afternoon, and good evening. Welcome to this new webinar series on mental health and COVID-19. We're coming to you from all across the world and you're joining us globally as well. It's good to see so many of you are online. Thank you very much for joining us. I know how busy everybody is, and I promise that we will make very good use of your time. Now, this is a joint effort by United for Global Mental Health, the Mental Health and Psychosocial Support Network, the Mental Health Innovation Network, and the Lancet Psychiatry. I'm Niall Boyce, I'm the editor of Lancet Psychiatry, and I'd like to give very special thanks to the WHO as well for supporting us. I'll be chairing this discussion with our guests, Dévora Kestel, who is the Director of Mental Health and Substance Misuse at WHO, Sir Simon Wesley, who is the Director of the King's Centre for Military Health Research and is also the current President of the Royal Society of Medicine. Dr. Florence Ghana, who is a consultant for WHO, and Professor Neil Greenberg, who is the Professor of Defence Medicine. We'll start off with our panelists. I'm going to be talking to them about specific issues which they're specialised in. We'll then go through some of the questions which you've emailed us. If you'd like to email us any further questions, you can send them along to our email address, which is COVID-19 seminars, that's all one word, COVID-19 seminars at unitedgmh.org. So I'd like to start this first session with Dévora, and I'd like you, Dévora, to just give us an idea of the global picture. What do we know about the mental health effects of this pandemic?
Okay, thank you. Thank you for holding this, for organizing this seminar, and for having us there. Joining you. I see that there's a huge number of people participating, and this tells a lot about the interest of the topic. There are a few issues that we know by now, right? We know that in any crisis, it's natural for individuals to feel stressed and worried. And in this particular one, we have the fear on one hand of falling ill and dying, but also of losing livelihoods and losing loved ones and being socially excluded, isolated, separated from family and caregivers. And the uncertainty around the future is adding also to this concern. The economic consequences of what's happening that are uncertain, and then again adding to the feelings around this situation. And these are all normal responses to a crisis like this, but it doesn't mean then that are minor issues, or that because are normal, we should know how to deal with, or should be easy to cope with. That's what is impacting everybody, or the potential to impact the entire community across the 200 and something countries that are right now affected. But then we have the group of people who test positive to COVID-19, and their loved ones, the family members or friends, that is having an impact on the stress related to that, but also in many cases the stigma is very high, and we have seen that coming time after time from the very beginning. We have then the group of people with already existing mental health conditions, and this situation may be exacerbating those conditions, and there is, on top of everything, a limited access to services, and this of course will have an impact. Some noise background. We then have the group of frontline workers. We hear more about that also. They are particularly stressed with an incredible amount of workloads, in many cases switching from one area of work to another that may be completely new, and adding extra stress and concerns to that. And something that we are seeing, I'm sure we are all aware of, is that the stigmatization to those working in the front line is still also increasing. On one hand, there is the recognition and the effort some communities to manifest this recognition of appreciation, but on the other hand, also situations of stigma and the need for them to take care of themselves, and this is not happening easily. And then we have the group of people with specific vulnerabilities related to the current situation, such as families where maybe violence is an issue, so children and women that may be affected by violence within the family context, and the limited mobility that is right now, as well as older adults, children with neurological conditions, people with disabilities in general, and including psychosocial disabilities, pre-existing physical conditions, etc. So there are like different groups with specific needs, all around mental health and psychosocial support. We see that this stressful situation we are all in one way or the other going through globally, which is something very unique right now, has also the added risk of turning into alcohol, drugs, other addictions that will have other consequences that will only worsen perhaps the situation, and increase risk of mental health, violence, or also suicide. So this is a bit the very broad map that we see, and we have a lot, and we are learning a lot from high-income countries.
Yes, it's a considerable, yeah.
Yeah, as soon as we move, as we are moving, the situation and the challenges will probably on some aspects increase, and we will need to find solutions and ways of dealing with this that are completely,
and
or
there
should
is
be completely innovative.
Yeah, there's
Sorry.
considerable breadth here. I mean, you've really covered an awful lot of different ways in which this can affect an awful lot of different groups. Now, my next question was going to be, what do we know about what works? But there isn't going to be a single solution, clearly. There are going to be all kinds of solutions based on the effect and the group and the setting. I don't think we'll have time to cover them all in this 45-minute session, but is there anything we know initially about potentially effective ways of preempting these problems, preventing them, or treating them?
I think that one of the key issues is that we take care of ourselves, of our own mental health, protecting our mental health by incorporating some basic self-care strategies, and those strategies will be different from context to context, from person to person, and but they are common. Everybody should pay attention to that: eating well, physical activity, some routine. A lot of us are teleworking right now or working from home. We should learn how to do it properly. We should have enough sleep, try to get some time to really relax and learn how to do it. Those are common issues, basic ones that are for everybody. Then, as you were saying, another key element will be being in touch with friends, family members, with the loved ones, and we may have some facilities if we have access to the media, internet or other social media tools, it may be harder if we don't have access to that, and we need to find solutions in those cases. What we need to make sure is that the services that were once available are in a way going to be available, and we need to make sure that there is some creativity, innovation, and preparedness on how to make sure that services are available for high-income countries with the means and capacities that we have, but also for low and middle-income countries using different different modalities that may be needed. We are promoting this kind of innovative approaches by also trying to collect experiences from those who are right now developing new ways of taking care of those who need this kind of support. And there is, we can discuss later if there is the time, a call for stories, something that we launched in order to get as many information as possible and move into a research agenda that will be oriented to an answer to that question that is going to be built in weeks and months to come.
Thank you. Now, I'd like to pick up on one of your points with Simon. Now, one of the things which Dévora just mentioned was the situation for people who have pre-existing mental health problems. Now, I know that globally, you know, that the move has been towards community-based mental health care, and I really wonder if you've heard anything or know, can let us know how mental health services have been affected by this pandemic, and how in turn patients are being affected by it. I think, Simon, you might have to unmute.
You'd think I'd have got used to this by now, wouldn't you, in the last few weeks, but I still haven't. Good. So it does work better when you switch it on. Most things do.
Yes.
So we did a review in your journal in the Lancet on the impact of what we expected to be the impact of these restrictions. And I think we found 25 or 26 studies, usually from some previous epidemics. 25 of them found there were adverse mental health effects, and all 25 said that those who had pre-existing mental disorders were among the worst affected by this. So there's no question that that's the big issue. The problem of what to do with it, well, I can only really speak for what I know is going on here. First of all, a lot of the basis of community care has had to completely transform itself in the last few weeks, just as the basis of primary care has. And we have gone, in terms of the kind of digitalization of the national healthcare system, made more advances in 10 years, in 10 days than we have in probably the past 10 years. And it's been a remarkable transformation. So a huge amount of work has now been switched to various internet functions, Skype, Zoom, all sorts of things. And some of that's been working quite well, but clearly others haven't. And we found some people with severe mental disorders find it very difficult to adapt to, and we're not able to visit them as much as we should, or indeed as possible. Some have incorporated this into their delusional systems, which has also been a problem. So it's been difficult. The crisis structures have had to change, but we are seeing more crises. And what's worse is we think there's a lot more going on than we can. We also have a problem with our inpatient care facility, which is not a large sector, but it's still a very important one. We have a staffing crisis. We've had a staffing crisis anyway, but this has been made far worse by COVID. And we also have great difficulties with patients who find it very difficult indeed to comply with the basic public health measures that have been incorporated. And we seem to have been second in the queue to get PPE, protective equipment, that has been supplied to our colleagues in the acute sector, but has been delayed in getting into the mental health sector, although I have to say that is now changing. But I think that's a familiar story to everyone around the world, that the needs of our big sister hospitals with the shiny car parks and the lovely canteens and the beautiful architecture and paintings comes before our somewhat worn down and often shoddy estates. I don't think that's going to be news to anyone around the world. But it's been a big challenge. We've also starting to see a rise in certain disorders, for example, obsessive compulsive disorder, and we can anticipate as the pandemic goes on, this will worsen and it will be one of the delayed effects. The other group that we're seeing, which hasn't been mentioned, is the very strong evidence from the past and already in now, is the much higher rates of disorders in healthcare workers dealing with the pandemic. Many studies have found doubling or even more of mental health problems for reasons that we might explore.
Thanks. I think what I've been seeing is, to an extent, a continuation of the way that a lot of talk around mental health was going before this, which is that there's an emphasis on well-being for the general population, which is of course important, but really comparative neglect of people who have severe mental illness, such as psychosis.
Yes, I think that's absolutely true, Niall, and as you say, that's not a new phenomenon. In this country and many other countries, there has been a big change in attitude towards mental disorders, particularly in our country. The younger royals, when they were still in the country, I suppose, did a lot to promote well-being. We've had a huge investment in talking therapies, probably the largest in any country in the world, but the severe end of the spectrum has been relatively neglected. Not ignored, but relatively neglected, and has not seen the changes that we've seen in the rest of the healthcare system. And I think all the pandemic has done is amplified these differences. So we're seeing 500,000 people volunteering now to work with the NHS. I haven't seen very much about whether that has crossed over into helping people with severe mental illness, who must be surely the most vulnerable. I might have missed it, Niall. You've probably got your finger on the pulse more than me, but all the talk has been helping the elderly, helping children, doing shifts in hospitals, supply and things like that. But I haven't seen anything about where this is going in terms of mental health.
Yes, and maybe that's something which we can return to, which is how to put this up on the agenda. But for now, I'd like to just turn to Neil, who is one of your co-authors on the Lancet paper on quarantine. And I'd like to know a bit more, Neil.
Plugs, isn't it?
Yeah, that's enough plugs for the Lancet.
That's enough plugs for the journal.
Yeah. Okay, Neil, I wonder if you could, referencing any medical journal you wish, tell us about the psychological effect of lockdown and quarantine, which is really a situation which has changed dramatically for a huge number of people, something that we're not used to. What do we know about these effects, and what do we know about how we manage them?
Yeah, so as Simon and yourself have said, clearly we carried out a rapid review on this topic. Unsurprisingly, we found over 3,000 papers. When you whittled them down, there were only 24 that were sort of relevant. It's fair to say that the review we did was really early on during this crisis, when actually certainly in the UK, we were looking at bringing discrete groups of people back to the UK, keeping them in isolation or quarantine, rather than the whole country. And so although our studies looked across 10 different countries, it would be fair to say we weren't able to find situations like this global pandemic that we're facing at the moment. But I think what was really useful from that rapid review is there were some real nuggets of information that we could draw out. And basically, to put it shortly, what we find is that if you do quarantine or supported isolation well, actually, although it's frustrating and a bit disagreeable, it doesn't tend to cause long-term problems. But if you do it badly, and I'll explain what I mean by that in a second, then actually it can have not just a short-term impact, but actually the mental health impacts can be seen even many years later on. So good quarantine is where people understand the rationale and buy into the rationale for the quarantine in the first place. So I think in the current pandemic, if it were the case that actually we had very few deaths and no one appeared to be ill, but the government was still saying you must stay in, I think that would be hard for the public to buy into. But sadly, with the large numbers of deaths, I think that does reinforce the rationale for why this is an important intervention. The second thing was making sure that actually people had access to good information. So the sort of emphasis on altruism, on actually this being good for everybody, including the person themselves, and that having good factual information about what we know and not listening to the media too much, that seemed to be a very good aspect too. People also needed to have access to basic supplies, food and sanitary products and healthcare products. Certainly in the UK, we had at least an early on sort of lack of toilet paper and similar sorts of lack of paracetamol as well. I think things are sort of evening out a bit here now, which is a good thing. Unsurprisingly, one of the really big impacts of supported isolation or quarantine were the financial impacts. So if you lost money and you were financially really in difficult times because of quarantine, that led to significant mental health problems. But indeed, that would probably lead to mental health problems, whether the financial difficulties were due to quarantine or not. And the last kind of important aspect was about the length of quarantine. We found that, unsurprisingly, shorter quarantine was better. But actually, it was the extension of quarantine time and time again that actually had the potential to cause difficulties. Of course, that was in discrete groups who were separate from the rest of society. Whether that's the same when the whole of society is extended, I think remains to be seen. Just linking into what Simon said, which I think is important, is about healthcare workers, because we did find that actually healthcare workers were a group who were specifically at risk of suffering psychological impacts from quarantine, possibly because they weren't able to do the job, they weren't able to help save lives, which is what they want to do, and also because they kind of felt perhaps stigmatized because they couldn't help their colleagues and they wondered what people might think when they did go back to work. So overall, put it together, actually, if a government implements a quarantine or supported isolation package well, yes, it's frustrating and difficult, but it needn't cause problems. But do it badly, then actually it can have some long-term consequences.
Yes, it strikes me there's so much that we don't know. If I'd read a paper on social isolation, for instance, 3 months ago, would have meant something very different to what we mean now when we talk about social isolation. So to what extent is the body of evidence that we have really useful now when we have this uncertain period of physical distancing, social distancing, whatever we like to call it, how long people are going to tolerate it for, how we help people to tolerate it? How much does the evidence base really help, and is there any effort to collect data as we go to help in the current situation and future situations?
So certainly our team at King's College London, we're part of, Simon and I, Simon leads the Health Protection Research Unit. So we're very keen on looking at this topic, and actually, we're looking at some studies of the early groups of people who were brought back and put into quarantine for a period of time to see what the impact of that is. I think you're entirely right. I think in terms of how do we translate 24 studies across 10 countries in discrete quarantine situations into what is a global situation, I think is more challenging. The reason why I think actually those bits of information I mentioned earlier are relevant is actually they seem to be quite universal no matter which country or which culture you looked at. So I do think you can draw some nuggets out, but I would completely agree that we're going to need more work to understand what the real impact is. I guess the difficulty is it's very hard to have a control group in the current situation, although there are apparently a few islands, aren't there, in the South Pacific, but I'm not sure how representative they are of perhaps cultures like the UK.
Thank you, Neil. Now, I'd like to bring in Florence now. Now, one of the paradoxical effects of this is it's a global situation, but it seems to have made news reporting much more parochial than it was before. Everything I've heard about this pandemic is really related to things which are happening in the UK, in Western Europe, and in the US. I don't think there's much that we're hearing, certainly in the UK, about the situation in low-income countries and in middle-income countries. So, Florence, I wonder if you could tell us about the kind of impact which the pandemic is having on mental health in low and middle-income settings. I think you might be muted, Florence. Okay, I think Florence is not able to join us. I know that she didn't have a great internet connection. So I'm just going to give her a moment, see if she can come back online. Okay, I think we might have lost Florence. So what I'd like to do
is... I'm back, sorry.
You're back, fantastic. Did you hear the question? Brilliant. Welcome
Yes,
back.
I'm back. Yes, I had the question. I'm sorry. Indeed, reporting has been focused on high-income countries, as it should be at this present time, considering those who are affected. In low and middle-income countries, we have the same mental health and psychosocial issues. We also have people with worry and with anxiety about contracting the virus. Maybe an even bigger challenge for us is that not everybody who suspects they have it can actually be tested. There are very few testing centers and people don't really have access to the test. We have emergency rooms that are really overcrowded with people, and helplines that are overwhelmed by calls and by patients. And some of these, maybe the majority, actually people who don't even have COVID, but may have anxiety. They have symptoms that make them believe they may be having COVID, but they may not be having COVID-19. And so this also blocks access to the people who actually need help, and may also put some of those who go in physically to the emergency rooms, putting them at risk. Low and middle income country healthcare systems are actually gearing up for the peak of the pandemic, stocking up on personal protective equipment. This is one of the big challenges that we have at the moment. There are shortages of personal protective equipment, and they're being kept for only those who work in intensive care units, and some of the other healthcare workers are not being as protected as they should be. So it makes healthcare workers also very anxious when they have to go into work, especially those who are away from like the bigger centers. If you work in a more remote rural center or in a district away from the capital, you're very unlikely to have the personal protective equipment, and yet we know that the COVID can come up anywhere. In addition, low and middle income countries are grappling with increased incidences of violence against women. Some of what Dévora was talking about, almost every day in the news now we hear about women being beaten up. The extended time being spent together in a confined space without too much to do. In the daytime, very many people are taking up to drinking alcohol, some are using drugs, and the pressures of also not having an income. Many people are living hand to mouth. They have to work that day to make an income. If they can't have the money and then they have the children around them, it causes a lot of stress on the family units.
Yeah, I mean, Florence, one thing which I've been quite concerned about is that clearly there have been gains in global mental health in that picture over the past decade. And I wonder to what extent we might potentially see these gains reversed, see things actually going backwards as a result of this pandemic.
There may be, yes, it's possible there may be going backwards, but I think actually the pandemic has brought to light just how important mental health and psychosocial issues are, and how they are cross-cutting in the different areas of health. For instance, people who have HIV and AIDS right now are worrying about how are they going to get access to their medications. Those who have other non-communicable disorders like diabetes and hypertension, they're worrying about, will I be more at risk if I get the COVID? Am I likely to die? And some of them are also not getting access to their regular medications because of the big focus now on COVID and the difficulty of going into the health units. With the lockdown, it is almost impossible to get into a hospital for many countries because we are not allowing any cars to move. And so some people are walking. We've heard of women as well who have walked miles to try and get to a hospital for a delivery. So I think all these things are raising the importance of mental health and psychosocial issues. Also how they cut across like livelihoods. People's livelihoods are being impacted right now. And that too leads to, I'm hoping that in going forward, as we go forward and as we come out of the pandemic and get into recovery, I'm hoping hoping that people will recognize the importance of mental health and psychosocial issues.
Thank you. Thank you. And there's a question really arises from all of this, which I think maybe is one of the whole panel, which is the dividing line between what we might call an appropriate level of distress as an unusual situation, and then something which would be classified as a mental health problem that could do with some degree of professional help. Is this a distinction which matters in the current situation? I wonder, you touched on this, Dévora, when you spoke, so I wonder if you could maybe start. You'll have to unmute yourself, though.
I'm muted. Okay.
Ah, good. Yeah.
We're all struggling a bit, no matter how much we try. Yeah, well, this is a great question, actually. You know, we came up last year with a paper about some numbers around the emergency situations, and we say that 1 in 5 people develop mental health conditions during an emergency situation. But now we are in a situation where the vast majority of the population develops some kind of distress, as you say, because of the stressors that were just mentioned by everybody. So the particularity of this crisis is that it's global, and nearly everyone will be affected one way or the other. How do we deal with that as a society is a bit perhaps the challenge, and how we will maybe come up with a normalization of this stress that we all feel right now, and who can contribute to that, to helping going through this situation. Who else other than the health sector? Because we are talking about some of the issues that Florence just mentioned, or before, Neil also, whether it's going to be some social protection or other economic help, for example, will have an impact on the level of stress, distress of a person, and that will depend a lot on where you live. If it is in a high-income country or low or middle-income country, it will be different. The same, I was listening these days in some countries in Europe, I think in the US, some hotels being set up for women victims of violence at home these days. Well, that is hard to see it happening in low or middle-income countries, unfortunately. But we need to come up with those ideas. The issue of digital technology, the issue of what companies can do in order to make sure that the misinformation is out as much as possible, and so what others need to do in order to make sure that the health sector is focusing on providing mental health care and psychosocial support to those who need it, no matter where they are in with the new technologies or with other ways that we need to be put in place. The focus for us should be always how we make sure that those who need it get the answer they need, the support they need.
Okay, and Simon, I'd like to just talk about this issue of an appropriate response, because I know that a lot of your career has been about really showing how resilient people are, and how the tendency to intuitively think that counselling is needed straight away is maybe not always the best response. Now, next week it's going to be a focus on frontline professionals, but you know, I've noticed quite a bit of talk around immediate counselling and this kind of thing, and I wonder if there may be other things which might be more appropriate than that to preempt mental health problems.
Well, I mean, the first thing to say is, whether appropriate or not, the idea that we'll be able to counsel ourselves out of this problem, which is affecting 2 billion people, seems to me far-fetched. So, but the evidence also does suggest that certainly, just as you can intervene too late in a disorder, you can also intervene too early. And if you do introduce, for example, interventions such as what was known as psychological debriefing, although this is normally used after single traumas rather than what we're going through now, which is a rather more elongated and prolonged situation. Nevertheless, you can do harm. And the general rule is, you know, the first thing you have to do is to sort out the more immediate needs, and this applies to healthcare workers just as it does the population. So the immediate need is safety. So, you know, you have to give people equipment if they're going to be working in certain occupations. You have to give them supply. One of the things that Neil didn't point out in the other list of things that happens during quarantine, if the supply chain fails, you get civil disorder. You have to also reintroduce fairness and equity. So if people feel that during the crisis, that things weren't fair, that certain groups of the population got better treatment or got access to drugs or the vaccine first, you are storing up long-term problems as well. So you have to sort out the social and political and the communication aspects. I would thought before you can start thinking about the mental health problems, because in a society where there are resentments or groups that have felt to have caused this, well, it's unlikely to happen in the current situation, but it's happened in pandemics in the past, you will have a fractured and divided society, not conducive to mental health interventions. Then I think you can start thinking about providing some of the more standard mental interventions we shall do. I think the other question is, what will they look like? I've kind of believed for some time that although my colleagues in other branches of medicine may become redundant in radiology or pathology by digital, this will not happen in mental health and psychiatry, and there is still something about the face-to-face interaction with a real person that people still will need. This will be a good test of my hypothesis as to whether that's true or not. I suspect it may not be.
Thanks. I'm just going to go now because we're fairly short on time. I'm going to go to some of the questions that we've been sent in. And the first is from Selen from Canberra, who is working at the Multicultural Communities Council of Illawarra. And what Selen says is that there are many older people from specific cultural backgrounds who are suffering from isolation and are dealing with language barriers, and really emphasizing that there are issues with providing a culturally appropriate response. And this has long been, I think, an issue in global mental health, which has been how we go from, you know, exporting a particular rigid model of mental health and really being much more culturally appropriate and thus effective. So I wonder, Florence, if you have any insight. Okay,
Yes,
I think Florence might have muted her microphone
yes.
again.
No, it takes a
Great.
while. My internet is a little slow. Takes a while.
Oh, that's okay.
Indeed,
That's fine.
it's really important, especially as was mentioned, for the older people who are living in cultures that may not have been originally their own, to be able to reach them with the approaches that we have been forced to use at the present time is probably going to be a challenge, but I don't think it is one that is difficult to overcome. We know, for instance, that there are approaches that can be given one-on-one. And if somebody has been talking regularly with their grandchildren on FaceTime or on WhatsApp or whatever other media they are using, and they're talking to their grandchildren on a regular basis, then this same person should be able to use the same media to talk to a counselor or a healthcare provider who is talking to them to try and reassure them in this difficult time. So I don't think that would be almost impossible then. And in the same way, we also have different approaches that can bring different initiatives, innovations that can bring people into a room virtually. So just like we are here and we are talking and we have a big audience with us here, but in the same way, we could say bring 10 people in a room together and have a support session for the older people. They could be facilitated by somebody who helps them set it up in the care home that they happen to be in, or even within care homes. I'm sure they could come together and keep the physical distance they need to keep and be able to be facilitated to have a session, but they can also meet virtually online and support each other. We have innovations that have been out of out of Africa, I would say, like the friendship bench, where you would have to sit on a bench, but now you could sit on a virtual bench and talk to somebody. We also have the community sociotherapy, and these are also being implemented physically in Rwanda, Liberia, and Sierra Leone, but I'm sure that we can innovate and have these meetings in a virtual space.
Thank you. I'll just go to the next question, which is to do with the economic consequences. And I wonder if Neil maybe could answer this, this is from Alessandra, who says, a lot of people might lose their jobs. What do you envision the long-term consequences of this would be on people's mental health?
As I said in the earlier bit, I mean, there is definitely evidence that if you are financially sort of in difficult straits because of the current situation, then you will have or be at risk of suffering with long-term mental health problems. But it's the same if you look at economic downturns for any reason. You know, financial difficulties, whatever the cause, are definitely a cause of mental health difficulties. So I think certainly in the UK, if the government's offer to people is sufficient to stop them falling into really sort of dark poverty situations where they're having real difficulties, we would hope that actually, as well as being a financial intervention, that should also be a mental health one. But there can be no doubt that, you know, if you hit poverty, then you are more likely to suffer with mental health difficulties.
Yeah, so I think that it's not just the different groups maybe, which Dévora started talking about and the ways they're affected, but we also have to think about how this develops with time.
Yeah, absolutely. And of course, the impact at the moment is about very much about getting through this crisis and saving lives, which is completely understandable. You know, the pandemic impact on financial situations will obviously be felt later on. You know, many people will have savings for now, but the future that they might thought they were going to have will be somewhat different. And the same goes, of course, internationally. You know, each country is spending a lot of money to save lives, and somehow that's all going to have to be recouped over time. And I guess that bit's still to play out.
Thank you. So I'd like to just return to Dévora for one more question before we have a roundup question. And this relates to something that Simon mentioned earlier, which is putting mental health up the agenda. Because whenever I've heard mental health talked about, it's always been in the context of non-communicable diseases. And really linking the idea of mental health up with infectious diseases is maybe a bit different. How can we frame mental health in such a way as to make it a priority, which it should be for funders and for service providers and for researchers indeed?
One of the issues that I think it is important to bring to the attention at this point is a lesson learned maybe from the humanitarian community, and where mental health and psychosocial support is cross-cutting area of work, and it has its role in each one of the pillars or the areas of within the emergency context, whether it is health, protection, education, labor, etc. And this is what we see right now, no? With the discussions we are having. We are talking about different sectors where mental health and psychosocial support is a part of it and could be linked to it. And this is a way maybe of having mental health and psychosocial support at the center of attention, or more central than what it used to be, as it was discussed before, and linked to each one of these issues, and make sure that those in need of the specific care, again, do receive that care, but then that there are components of mental health and psychosocial support in each one of the other areas. We are, I'm amazed at the speed that the people working in the mental health and psychosocial support in the area of the Interagency Standing Committee has moved. And I was recalling at your previous question when you were talking about what somebody was asking about the cultural issues. The group came up with a book for children last week, and in 2 weeks we received inputs from 1,700 people from 104 countries. The book was released a few days ago, end of last week, if I'm not mistaken, and is already translated into 44 languages. So that's how also we can reach out, and we can make sure that then at every level, this is education. This is educating the kids about what's happening. So at every level, we bring this perspective. But always, let me repeat,
yes,
not forgetting those who really need the specific technical support, clinical support, mental health and psychosocial support.
So that leads me on nicely to my final question, which is for all of the panelists in turn. And if you could answer this in no more than 30 seconds and preferably 15, that would be superb because we're very short on time. And the question is, what do you think should be the single biggest priority for mental health service providers at this moment in time? I'd like to start off with Florence.
If I am to give just one, because I have a few priorities, but if I'm just to give one, I would say the support for the mental health, psychosocial support for the healthcare workers, because they are at the front line of the support being provided to those who have been affected by the COVID. And if they don't do it well, then people will be reluctant to go in for care. So limit the hours that they work, maybe 4 hours only in intensive care. Ensure they are protected, ensure they have personal protective equipment, psychological first aid, regular debriefing, training, reorientation, all these are really important. So that would be my one.
Thank you. Simon, what's the single biggest priority as far as you're concerned?
Well, Florence has just used my own personal exit strategy from this webinar by talking about the workforce.
Yes.
So I'd have to change that quickly. I think it's not to lose some of the gains that have been made, because I think there has already been some remarkable innovations that have been made that we shouldn't just go back to how it was, although please God it doesn't involve staring at computer screens all day. And also to recognize some of the benefits that have come of the use of a volunteer workforce. Maybe we also can use different ways and cheaper ways of helping people that we've just got to invent as we go along. Is that we don't go back to exactly how things were, and we recognize that actually out of chaos will have come quite a lot of very useful things that we should now stick with even when times get better.
Thank you. Neil.
I guess I would support what Florence said as well. I think if I had one thing to say, I think given it's predictable that people who are vulnerable to develop mental health difficulties, who have OCD, who have health anxiety, they're all going to find this particular situation tough. I think that mental health services remotely, obviously, should be reaching out to these people proactively and trying to prevent them becoming a crisis case and then having to get into significant mental health care. So proactive reach out to people who we already know are at risk. Don't wait for them to phone us.
Thank you. And Dévora, what's your single biggest priority?
Well, a bit from everybody. I mean, adapt. What you have been doing so far, adapt to the current situation and deliver. We need service, mental health service delivery available to all those who need it. Learning from what has been done, preparing and doing right now with the conditions we have in order to answer to all those issues raised before by the colleagues.
Thank you very much. And time is up, unfortunately, but I hope that everyone who's joined us this week will be able to join us again next Tuesday at the same time, when the discussion will be about the mental health of frontline workers, including representatives from WHO and the Red Cross. The chair will be Harvard's Shekhar Saxena. I really hope you can join us all again. But for now, I'd like to thank all of the panelists who've joined us, and indeed, thank you to all of you for listening. And we'll see you again soon. And but for now, goodbye.
Thank you. Goodbye.
Bye.
Thank you. Bye-bye.